SA node containing area is located at the junction of the right atrium and superior vena cava. I find it handy to identify this by again inserting my thumb through the incision I have made into the into the right atrium, with the tip of my thumb extending out the cut edge of the superior vena cava. The sinoatrial or SA node is located where I'm indicating here at the junction of the superior vena cava and right atrium in a groove known as the sulcus terminalis. The landmark externally is the crest of the atrial appendage as it ascends upward to end in the sulcus terminalis. And so right here is about the midpoint of the normal SA node. To study the SA node, the method that I prefer is to actually excise the area that contains the SA node, and then subsequently to section that into long strips and study those and place those in cassettes. In order to get this section, we use as the midpoint this junction of the atrial appendage and superior vena cava, again where I'm indicating with the forceps. The first cut I make is medially, about 1.5 to 2 centimeters medial to that point I talked about, and I just go all the way up and out the superior vena cava. Then the atrium can be folded over, and I'm going to lay this slowly down here. Can be folded over, and we can identify a ridge here as I've outlined by the scissors. This is the crista terminalis. This is the landmark that we want to preserve because the SA node is located in the sulcus terminalis, located on the epicardial side of the crista. Our second cut is made perpendicular to the crista terminalis on up to the superior vena cava, and we will end up with an approximately rectangular piece of tissue. As long as we go at least a centimeter above the crista terminalis, we will be in good shape for having sinoatrial nodal tissue. The next step is to excise that area containing the AV node, His bundle, and bundle branches. This is accomplished by opening up the right side of the heart and identifying several landmarks. We have here exposed the right atrium and the right ventricle. The key landmarks that we will utilize for identifying the area containing the AV node, His bundle, and proximal bundle branches are as follows. The coronary sinus, in which I am inserting the forceps, the valve ring of the tricuspid valve, which I'm outlining with the forceps, and the membranous septum, which I am indicating with the tip of the forceps. To identify, another way to identify the membranous septum is to transilluminate it, which I will attempt to do with an external light source, and there it is. This is literally a fibrous piece of tissue that forms the uppermost portion of the interventricular septum and is a landmark particularly for the location of the His bundle, which is located along the inferior margin of the membranous septum. The cut that we will want to make to include this tissue will be made just anterior to the coronary sinus. It will extend down through the valve ring of the tricuspid valve. It will extend along the interventricular septum past the membranous septum, Then we will go upward approximately 5 to 10 millimeters, 5 to 10 millimeters anterior to the membranous septum, and then we will join our initial incision. We want to include tissue in our initial cut approximately 1.5 centimeters or so above the ring of the tricuspid valve and 1.5 centimeters or so below, and we will end up with a roughly rectangular piece of tissue. And this is indicated by the base of the triangle being a line drawn from the coronary sinus to the valve ring of the tricuspid valve, and the apex being located at about the membranous septum. A structure that's very difficult to see, but that courses from the top of the coronary sinus and inserts into the membranous septum is called the tendon of Todaro, T-O-D-A-R-O. But anyway, using those landmarks, we will now excise the tissue that contains the, and then again cut, the first cut being made just anterior to the coronary sinus and all the way through the thickness of the heart. The next cut, we will have to turn this a few degrees, is made approximately parallel to the valve ring of the tricuspid valve. And we will maintain a thickness of about 1.5 centimeters below that. And we can just cut all the way through this tissue. We do not need this other tissue anymore. The next cut, which is perhaps one of the more challenging cuts, is to extend approximately 1 centimeter anterior to the membranous septum, which again is here where I'm indicating with the knife. And one just cuts through all the tissue. And the final cut is made with the nearly excised rectangle of tissue. The final cut is made extending about 1.5 centimeters above the tricuspid valve ring. Some individuals, if they wish to study more of the right bundle branch, will take an additional block of tissue beneath this one for 1.5 centimeters or 2 centimeters. Just in summary, the two pieces that we should be left with are the SA node containing tissue, as indicated by this first somewhat larger piece of tissue. It's a little harder to tell now that it's been excised, but on the epicardial surface, the upper third is the superior vena cava, the lower third is the right atrium. If we turn it over, it's much easier to identify the landmarks because the crista terminalis is identified on this endocardial surface. Again, with regard to the AV node and His bundle containing tissue, we have more or less a rectangular piece of tissue with the midpoint being the tricuspid valve and the upper half consisting of right atrial endocardium. The first indication is to get the pieces into an appropriate size that will fit into the cassette, but we want to include the important tissue. We can therefore remove a lot of the tissue from below the plane of the crista terminalis and from above the plane of the crista terminalis. And we'll do that with a regular scalpel. Knife. And we simply make parallel cuts beginning at one end We lay the pieces on their side, and if we put the side down that we have just cut, and by way of example, I will show that we will lay these two pieces in a cassette. There's no minimal or maximal thickness. Usually 2 to 3 millimeters is desirable, and 2 pieces can fit into a cassette. And we continue with the other sectioning. The architecture of the SA node is such that the nodal tissue is grouped around the artery. If you see the artery, then you know that you have got the node containing tissue. In this case, we have 2 small arteries, and sometimes the SA node artery will bifurcate into 2 branches. There are 2 arteries at about the junction of the atrium and superior vena cava that indicate that we are in the region of the SA node. We know that this section, probably the next 1 or 2, and perhaps the 1 or 2 prior to it, will contain nodal tissue. Our next piece of tissue again contains the AV node, His bundle, and bundle branches. I normally will start on the most posterior portion of the section, which I'm indicating with the forceps, and work anteriorly. And I'm going to turn this upside down because I'm right-handed. And the first cut is a little rough because the posterior edge of this specimen might be a bit rounded off, but one does one's best and tries to get a thin piece of tissue, and one can lay it out as I have, and then we cut approximately every 2 millimeters going anteriorly and lay the pieces out. Membranous septum is indicated by this very thin, several millimeter length of white fibrous tissue. We load the pieces into the cassette, keeping the original cut side down. Now, some, as this one is, are a bit large. We can afford to cut the top of the piece off to make it fit. We could also cut a little bit, if we had to, of the inferior surface of the septum. But the pieces are then placed in the cassette, as I have done. A pilot section from each of these is cut for the pathologist to determine which pieces will contain the AV node, and His bundle, and proximal right bundle branch, and then again levels through the block as I described with the SA node can be made.